Hi, everybody. Welcome to tonight. We're going to talk about plastics and reconstructive surgical procedures. This week, we have done orthopedic, neurosurgical, cranial, neurosurgical, spinal, and peripheral. And then tonight is plastic and reconstructive procedures. Okay. Don't forget to do your brain surgery and Slack participation. We're going to talk about facelifts and skin grafts. All right, so it is very important to know your muscles and your bones. You have to be right up there with the surgeon, okay? And about your skin. So, this is your frontal bone, right? This is where your eye socket is. So you'll see your sphenoid bone coming in and out, your optic foramen, lacrimal bones, nasal bones, all the way down to your volar, to your maxilla, and your mandible, the jaw, right? Very important to know. The upper face containing the frontal bone, the mid face containing ethmoid, nasal bone, zygmoga, and maxillary bones, and the lower face containing mandible. Then on your skin, this is important when we do full thickness grafts. So you'll see your epidermis, which is the top of your skin. The next layer is still part of your skin, but it's the dermis. And then you have your subcutaneous fat right here. The yellow usually tells you that's this subcutaneous fat. And in this, when we take a dermatome to someone's skin, you also have your sweat glands in there and your follicle for your hair, right? All that goes with it, including your nerve endings, which has a lot to do with what we're going to do when we replace someone's skin with a graft. Okay. So again, your epidermis is the outer layer of the skin, acts as the first line of defense against external factors, maintaining homeostasis and supporting sensory functions. And then your dermis, which is right below all that, right here, and it sits right on top of your subcutaneous, houses nerve endings, oil and sweat glands, blood vessels, and hair follicles, just like I said. What does it do? Well, it nourishes and innervates the epidermis, oxygenating tissue, regulating body temperature, and sending sensory signals to the brain. And then you can see right underneath your subcutaneous fat is where your muscle layer starts. All right, plastic and reconstructive surgery crosses nearly all subspecialties. Surgeries involve the treatment of defects and anatomical abnormalities. Our primary goal for plastic surgery is to restore form and function. Case planning includes common procedures like prepping and draping, preparing instruments, and some of these may require orthopedic instruments. Plastic surgeons, they do breast dogs, facial stuff, facelifts, blepharoplasties. They can even do carpal tunnels, just like orthopedics. ENT guys, also work on the face. They're more in the nose and stuff, but they too deal with Mohs, surgery, cancer, and they have to work around on the face. So what can we do? Well, we can do brow lifts, lifting supportive structure of the brow right up in here. We could do blepharoplasty, which is the resection of eyelid to improve the vision of upper visual fields. A lot of times it gets really thick right in here and it droops over. That could make a patient not be able to see correctly, or it could even cause blindness because it's always rubbing on the eye. I've been in many cases like that, and we've had to remove some of that. Otoplasty, modifying the external ear to correct ear deformities. Some ears, maybe stick out a little bit more. Maybe we need to tack them in. Sometimes there might be some kind of other deformity that we'll fix. Okay. But we can do a lot of things to the outer ear, or as we call it, the auricle. The malar augmentation, increasing the height of the cheekbone right in here. Right, we can give somebody cheekbones or higher cheekbones. And then mentoplasty, the chin. We can put in chin implants. Some patients come where they don't hardly have a chin, and we can put one in. All sorts of, give them a bigger chin. We can do all sorts of different things. So be in mind of your midterm definitions. Facelift equals rhytidectomy, and you can see ectomy is we're going to remove, right? And rhytid is a wrinkle. So if we do a facelift, we're going to pull back everything and remove those wrinkles, okay? Otomy means incision, okay? Ectomy means excision. So I'll have to get this fixed, but that's right here is actually wrong, okay? So this picture here shows a lady before picture, and then after we did a facelift or a rhytidectomy, how everything gets pulled up. They're showing here where we pulled down and where we pulled back to pull the wrinkles out. So why do we do this? Well, aging, gravity, external factors, or smoking can impact skin and underlying structures, leading to wrinkles, skin laxity, hollow areas around the eyes, nasolabial folds, and jowls right here. So, and we'll just follow right here along the hairline. That way there's no scar down the middle of the face, right? It's all in the hairline. So it's one way to hide that. So the patient position is usually supine with the head stabilized on a donut or a Mayfield headrest. We'll just make a round little donut, exactly what it says. We can take towels, wrap them in Coban or whatever, and the crown of the head, back of the head lays on it. That way it's up off the pad, but still resting. We prep the face and face exposing the frontal scalp, right? Because we're going to do all our work right here. Povidone iodine is used to prep the skin for surgical procedures. But again, as we learned before a couple weeks ago, we have to be careful that we don't get it into the eyes or into the ears. Into the ears, we can have them lose their hearing. In the eyes, we could have them go blind. Sometimes there's a solution that we use. Kind of I mentioned this a couple weeks ago about a weak tea where we water it down and we wipe it. Again, I would say we put cotton in their ears, surgical cotton in their ears while we're prepping, and then pull it out because we definitely don't want nothing to pull into their ears or their eyes. On the hair, because our hair lays loose, we want to put some KY jelly or something so it stays back and it's slicked back. Even though we're going to drape the hair out, you still don't want little hairs to come out while we're doing the work on the hairline. So draping notes, this is kind of what I'm talking about with the drape. So the head drape is used for exposure of the face, nose, and throat materials, as you can see right in here. So we're going to use a full or 3/4 plain sheet, half plain sheet, 2 surgical towels, optional plastic towel drapes, and a split drape. So here we go. This is 2 folded sheets over each other. You can see the one is in a darker blue and this one's in a lighter blue. Then over here, what happens is anesthesia will lift the head up because of the O2, the LMA in. We're going to lay this sterilely below, hitting the neck with the bottom one. And then the second one, we're going to take and we're going to wrap up and see here, covering all the hairs we can, the ears, right? And then we're going to take it and we're going to use a penetrating towel clamp. But you see how we don't see any more hair up in here, correct? And then that's how we drape that out. Just gotta be careful that we don't touch the LMA and the hose from anesthesia because that is not sterile when we're draping. This is actually called a head drape. Instruments that we use to get the rhytidectomy done is obviously you're gonna need a knife handle, a number 10 and 15 blades, mets and bombs, because we got to do a lot of dissecting. We got to lift all our skin up off our face right here so we can pull it back. Skin hooks, so while we're pulling everything back, we gotta lift it with a skin hook, and that way the excess we can cut to suture. And then rhytectomy scissors. They look like tenotomy scissors. Surgeons will want that on their field. Sometimes we will use a lighted retractor. It is frequently used in plastic and reconstructive surgery. In the cases that I've done over the years with my surgeons, I've never used a lighted retractor down in here, but if it's on this preference card and the hospital carries it, then we use it. It shows you can see way back in here as we're pulling the scalp and the skin away. Okay. Steps to get this done is make the skin incision with a 15 blade. Use a double pronged skin hook for retraction. Continue dissection with rhytectomy scissors and the bovie, the ESU. So this is what I'm talking about, the main incision hairline around the behind the ear. So we're going to go right along the hairline of the patient, all the way down right in front of the ear, and then we can carry it on depending on what's going on. And we just follow along the hairline. Trim the skin after we pull it, right? And we got extra skin and it looks taut and looks where the surgeon wants it. He or she will cut that extra skin and then work around the skin line. Okay. May use again a light retractor. Close the subdermal layer with a proximal sorbable suture. So basically anywhere along here, after we pull the skin, cut it, fit it, we'll kind of use some sutures to hold it in place, and then we'll suture the suture lines. And that way, any scars will be in the hairline and in your neckline, right? Behind the ear, in front of the ear. And then we close the skin.
A facelift can smooth out the facial skin sagging and wrinkling, in particular, the jowl regions and the sagging upper neck. When it comes to facelifts, intimate knowledge of the different layers of the facial skin is essential. Immediately below the skin is the subcutaneous fat. The fat provides volume and smoothness to the facial contour. Next is a thin fibrous layer known as the SMAS, which stands for Superficial Muscular Aponeurotic System. It is a key facial support structure that the overlying skin rests on. Finally, the underlying salivary gland, muscles, and nerves are present. First, the facelift incision is made hugging the ear boundary and hairline. The skin and underlying fat is lifted off the SMAS layer. This skin undermining is performed all the way forward to the eye, nose, and lip, as well as downwards over the upper neck. Strategic incisions are made to the SMAS layer, which is then elevated off the underlying facial muscles. Next, the freed SMAS layer is then pulled both upwards and backwards. After suturing the SMAS layer into its new position, the facial skin is similarly pulled upwards and backwards. Excess skin is removed, followed by suturing. Please note that the areas immediately around the eyes and lips are not improved with a facelift and require other additional procedures to make them appear more youthful.
So that's a little bit of how they do the facelift. Skin grafts. Now we're going to talk about some skin grafts, okay? Skin grafting is a common procedure in plastic surgery with biological, synthetic, and biosynthetic grafts. Minor injuries can regenerate sufficient skin to create a scar. However, large defects require a skin graft to protect underlying tissue from infection and injury. So the way I look at this is like this. You're riding a bicycle and you fall and you scrape your knee and all the skin's kind of gone, right? You put some salve on it, put a Band-Aid on it, keep it clean, wash it, it grows back, right? And your knee's good. Might have a scar, but your knee is good. If you're on a motorcycle and you're in shorts or not in shorts, um, and you fall going 20, 25 miles an hour or faster, and you ride along the street, scraping your entire leg, okay, or your arms, all your skin is gone. That's too big of an area and probably too wide of an area for it to heal properly and to grow skin over it without getting an infection. So this is where we have a skin graft. There's two different kinds. There's split thickness and full thickness grafts. The split thickness grafts contains epidermis and papillary dermis. It's a highly bioactive portion of the dermis. When you think of split thickness, think of this. So you see your epidermis right there, and this is your dermis right here. We split the dermis, okay? That's how much we'll take for the split thickness. Now, if we need all of it to cover, then we would use the full thickness skin graft, which contains the complete dermis and epidermis. So then it gets cut off right by the subcutaneous fat. So full thickness, all of epidermis and dermis. Split thickness is half of the dermis. There are three categories of materials all used in skin grafting. You have biological, derived from living tissue from another person, which is allograft. From the same person, say I need a skin graft and they're going to take it from me, that would be autograft, or from other species, which is xenograft, Xenograft. Synthetic is derived from manufactured materials. Biosynthetic is absorbed by the body or enhances healing, but is not derived from biological tissue. We as STs should always be familiar with the terms used to grafting techniques. So when we do a split thickness graft, STSG procedure, split thickness skin graft, the patient position is depending on the graft site. We could take it from the buttocks, and so we would have to prep out the back, and we'd have to prep out wherever we're going to put that skin. Okay, so it depends on where we're taking it from and where it's going to go. And same as prepping. Draping, again, is according to recipient and donor sites, so it just depends. Prepping for autograft requires two separate prep donors and recipient sites. Clear prep solutions are used on the donor site. This is necessary to maintain a clear view of the vascular bed of the graft. If we don't have a good view of that vascular graft, and the vascular graft is what's going to make the healing process begin correctly. Lack of vascular, it's just going to die off, and we'd have to repeat the process. It is important to maintain an aseptic barrier between the donor and recipient site, right? Everything has to be aseptically done. I'm going to show you a little video real quick on the dermatome.
Pneumatic dermatome, various components are put together and the safety precautions while doing that. This is a pneumatic dermatome. The front end has two rollers which control the skin graft as it comes out. The back end is the connection to the pneumatic air hose, connects the clip fashion like so. The other end of the air hose connects to the main air supply. On one side of the dermatome is the lever to control the thickness of your skin graft, marked from 0 to 30 thousandths of an inch. Along the base of the dermatome are two screws to secure the base plate and the central lever to secure the skin graft plate. The main control of the dermatome is the lever along with the safety sliding mechanism. Whenever the dermatome is in safe mode, the lever sits flush with the handle. Activate the dermatome to take a skin graft, lift up the lever, slide back the safety mechanism so that the lever stands proud of the base. It is equipped spring mechanism to set the dermatome going to take a skin graft. As far as base plates are concerned, come in various sizes depending on the width of the skin graft that you need to take, ranging from 1 inch to 4 inch. Base plate itself has got 2 holes for the screws to secure to the base of the dermatome. It has got a wider section to slide through the screws and a narrow section to secure the plate itself. The dermatome blade, be very careful when handling it to avoid a sharp's injury. Open it, always handle it at the base where the plastic strip is. It's very clearly marked. Insert this side up. It's got a central hole which corresponds to the lever in the middle of the base of the dermatome. When it sits in that lever, it sits flush to the base of the dermatome. To secure the base plate, slide the screws through the larger holes of the base plate and then slide the whole plate forward until you hear a click. And then tighten the screws, secure the mechanism. Once you have tightened it, make sure it is secure and plate round. At this stage, also calibrate the thickness of your skin graft, which is usually between 6 and 8 thousandths of an inch. I'm going to tell you now how to take off the skin graft blade once you take it off your skin graft. Just make sure that before you start dismantling the pneumatic dermatome, the lever is on safe. Once you have taken the skin graft, slide it on safe, make sure it's flush with the handle, then disconnect the pneumatic hose from the base so that it's easier to handle. Secure it on a nice and flat surface. Unscrew the screws at the base plate. You don't need to take the screws off completely. Once they're fairly loose, the plate should slide. You can see from the side, there's a little indentation at the side, which you lift up the plate and then slide it back. Once the screws are sitting in the larger holes, the plate should lift off. Similarly, when you take off the blade, always control it from the back, plastic, metal. Never hold it from the front. Once you have taken out the shaft, always put it in a shaft bit. That's how you assemble and disassemble pneumatic dermatome in a nutshell. Thank you very much. I hope you found it useful.
So that's how you put the blade on a dermatome. And then if you saw on the video, they had different sizes. It's one size blade, but then the piece that goes on top comes in different lengths, if you saw that. And so that will also help. And then when he showed you at the very beginning, you can turn it to the thickness of what we're taking from the patient. All right. Prepping for autograft recap requires 2 separate preps again. Again, clear prep solution, and it's important to maintain aseptic technique. For skin grafts, for split thickness, minor plastic surgery set is usually what you'll use, including fine scissors, fine Adson brown, and brown Adson forceps, and a dermatome. You can see this is your Adson plain here or with teeth. I can't see the tips. And then this is that brown Adson they were showing you last week when we reviewed instruments again with all the little teeth. That's the brown Adson. So again, here's the different size. You see how the different sizes are? That's just only going to go that length. This is going to be a little bit longer, and this is really long. A is the Paget dermatome. B is Zimmer dermatome with blades, all the different blades. And then C is the handle guided knife dermatomes used mainly for debridement. So a couple different ways. During prepping, mineral oil is applied to the donor side to reduce friction as the blade glides over the skin. You want it to glide smoothly. You don't want it to be chunky, and we don't want it to burn the skin either. Because if we burn the skin, then we have another problem, because now we got to deal with the burnt skin. Steps procedure is harvest the graft with a dermatome. And you can see here it is in motion on top of the leg. Grasp and elevate the graft with fine Atson or brown tissue forceps. Mesh the graft using a graft mesher, which this is right here. This is the plate, and we're going to slide it through here, and it meshes it just like this. This is what we want. Feed the carrier plate and graft into the graft mesher. The graft is aerated and graft. Secure the graft over the recipient site. Construct the stent or bolster to maintain contact between the skin graft and the tissue. So as you can see here, the skin graft has already been put in. You can see where we aerated or meshed it. Also, you want to make sure that the vascular is good here, which is nice and red, so it's good. We sutured in, leaving our suture long, our tails long, okay? Because then we're going to place a Vaseline gauze, which is right here, all the way around, on top of this graft. And then we're going to top it off with surgical cotton or other material that the surgeon would like. And then we'll bring these sutures together and tie a knot. The Vaseline gauze will keep the graft moist, and it also has some medication in it as well, so it helps with healing process. We can take potential graft sites, sorry, where the body has loose skin, and some places like that is in your hand, you know, it's loose up there. Your elbow, your neck area, behind the ear, down in your abdomen, pubic area, and of course your buttocks has loose skin. There's some sites. So here we're going to take a graft. You harvest the graft right behind the ear, as you see, you know, because there's skin, and it's behind your ear. So when there is a scar, it's hidden. The surgeon will trim the fat from the graft where you see right here. We'll lay it out. We will design it to fit where we're going to put it, and we also will put holes in our graft. We will suture our graft in, again, leaving our suture tails long. So when we put the stent or the gauze on top, then we can tie it on there, and that's how it stays. So facelift is rhytectomy, right? And then our skin graft. Again, please know your bones. It's very important to know your facial bones or any bones of the body for the cases. Trust me, those surgeons will ask you questions and they expect you to know them. We learned about open reduction, internal fixation, orbital floor fracture, mid-face fracture, mandibular fracture, and then your maxillomandibular fracture with application of arch bars and tooth extraction is next. So closed reduction means we do nothing that we're going inside the skin. We're not making any cuts, nothing. Reduction, open reduction, surgical access through an incision to bring bone fragments into anatomical alignment. So if I broke my finger and my finger was all messed up, we're gonna open it up. We're gonna line it back up, okay? We're going to fixate it with screws, a plate, anything to hold it, a pin maybe. And then we're going to take x-rays, make sure it's all still lined up. And then we're going to suture it closed, maybe put a splint on it, whatever. Okay, so open reduction is open. How are we going to reduce whatever's going on, fix it, and then now we're going to hold it until it stays fixed. And that's your internal fixation. So ORIF is employed to handle facial fractures as well, because remember, we're doing the maxillofacial surgery. You can have Lefort 1, 2, and 3, orbital floor fractures, blowout fractures, maxillary and mandibular fractures down in here, and fractures involving all 3 maxillofacial segments. I'm going to show you a little thing about Lefort so you can remember which one is which. Here we go.
Welcome back, everyone, to another episode of Quick and Easy, a series on the EasyMed channel where you learn medical topics in a couple minutes. Today, you're going to be given a simple trick to remember the different types of mid-face fractures using the hear no evil, speak no evil, see no evil saying. So the first fracture type is speak no evil. This is a Lefort type 1 fracture. This is a unilateral or bilateral fracture through the inferior maxilla just above the roots of the teeth. If you grab onto the central incisors and pull, there will be a mobile palate. So this is a Lefort type 1. It involves the maxilla, which is speak no evil. The second type of fracture is see no evil. This is a Lefort type 2. This is a bilateral fracture that extends from the maxilla, travels superiorly through the orbital floor and rim, and then medially through the lacrimal bones and across the nasal bridge. It's shaped like a pyramid. And in this case, if you grab onto the central incisors and rock them, the nasal complex is going to be mobile. So this is a Lefort type 2. It involves the orbits, which is see no evil. The final fracture type is hear no evil. This is a Lefort type 3 fracture. This is a fracture that involves the nasal bridge and spreads laterally through the medial and lateral orbits, and then involves the zygoma. So in this case, if you grab onto those central incisors and rock them, the entire face pulls anteriorly. So this is a Lefort type 3. It involves the zygoma, which is hear no evil. Hopefully this gave you an easy way to remember the different types of mid-face fractures. If you found the video content useful, don't forget to subscribe so you don't miss out on future videos that make medicine easy.
That's a good little video to help you learn what is what. I'll tell you, I wouldn't want to have any of those fractures. That just looks so painful. So surgical procedure in an ORIF approach, fractures are reduced again. We got to put everything back in place. Bone fragments are brought into normal position and fixed in place with orthopedic implants. In case of injury to the eye, orbital floor fractures, the ST should ask the surgeon which specific sets are required for the repair, because we got to know if we need screws, plates, or wires, kind of drills, kind of screw drivers do we need, all sorts of different things. Okay. Why do we need to do this? Because there's a misalignment of the teeth and jaws after accompanying facial fractures, right? So I'm dealing with a bad TMJ. So I can only imagine having a fracture, how bad that feels, especially with the pain of a TMJ. So as you see here, maxillofibular fixation, which is also an MMF, is a procedure to wire the jaws in a closed position with an arch bar. So we're going to wire all this together so you can't move all the way around here. Almost like braces, right? Except we're going to keep that mouth closed so it heals. Arch bars used to maintain stability of the upper and lower jaws during the procedure or for extended use while facial fracture heals. It's horrible. So the pathology here on a skin debridement of burns is tissue damage from burns continues after the event. Debridement may be necessary for any type of contaminator or complex traumatic wound. So you can see your first degree, your second degree. This is where it becomes third and fourth degree, is where we have to step in and debride and put some grafts in there. Severe burns require repeated debridement to remove dying and dead tissue so that healing can continue. So growing up, I had a friend that was playing with fire and caught himself on fire. And in the hospital, they had to keep taking the dead skin off and then putting stuff on top. It was horrible. So that's what they do, and it's very painful to the patient. But if you don't do that, then all those dead cells will start getting like fungi and stuff in there, and then it's causing more like damage. So it causes an infection and it could lead to death. Mohs surgery for skin. This is one of the serious surgeries or cases right here for cancer. But malignant skin lesions may be due to excessive exposure to ultraviolet light in combination with genetic susceptibility. Common types of skin lesions is basal cell carcinoma, squamous cell carcinoma, and the most concerning one is a malignant melanoma. MMS excises a malignant skin lesion by systematic removal of the margins and immediate microscopic examination. MMS is combined with frozen section, analysts allowing for rapid microscopic assessment and enabling wide excisions if needed. So in this video, which I'll show you, you see this is the cancer site, I'm going to say, where you're going to take it out, right? And we're going to send it as a frozen section. So then pathology is going to get it, and they're going to view it, and they're going to look inside they're going to slice it, and they're going to look inside their slides. And if cancer cells are still on the margin, they're going to call back and tell us to take more off around the area, because they still see cancer cells on the sides. Once we do that, we'll send the new section over there. And if they stop seeing the cancer cells on the outer margin, then we're good and the patient can go home. So let's show a little video of this. Sometimes it plays. There we go.
First, your fellowship-trained Mohs surgeon marks the tumor with a pen. While there is no need for the patient to undergo general anesthesia, patient comfort is a priority. So before the Mohs surgery procedure begins, the affected area is numbed with a local anesthetic. Then the surgeon excises a saucer-shaped piece of tissue with 1 to 2 millimeter margins around and below the marked border. Hatch marks are made on the skin to maintain specimen orientation. A bandage is placed over the patient's surgical site, and he or she will wait comfortably while the excised tissue is taken to an on-site lab where it's prepared for microscopic evaluation. Many Mohs procedures can be completed in several hours, but some cases will take longer. Your fellowship-trained Mohs surgeon, who has training in skin pathology, carefully examines the tissue under a microscope to see if the cancer has been completely removed. If residual tumor is found, it's marked precisely on the map. A second Mohs layer is excised only in the positive area. This process is repeated until all the margins are free of tumor.
Definitely have to get the cells. We got to make sure that we get everything, right? Scar revision. Scar revision is performed to remodel a previous scar. Surgical revision aims to remove the old scar and create a new pattern that is less noticeable. They can use a Z-plasty or a W-plasty. I find plastic surgeons and ENT surgeons that do this are kind of an artist in a way, because it could be a big scar and they can make it look really good, you know. Once this is all healed up, that scar can be hardly noticeable, if any. Breast augmentation is also under plastics. This procedure is performed to enhance size and shape or create a new breast after mastectomy. An augmentation uses implants or transplanted tissue. Implants typically have a silicone outer layer with a saline or silicone filling. Tissue expanders might be used to create room for implants by gradually inflating with sterile saline after fitting it into the tissue pocket. So some surgeons go underneath the muscle and some go on top of it. My surgeons I work with always went on top of the muscle. So what we do is we make a small incision. Ooh, sorry guys. We'll make a small incision right here. We will open up the cavity and then we would slide the implant, whether it be already filled with saline or one that we would have to fill up with saline underneath here, get the correct size and sew it up. And that's what that would look like. It's a breast implant. Breast reduction mammoplasty. Why do we do this? Well, this procedure is to reduce breast size for cosmetic or medical reasons. Maybe the back hurts or cervical pain, whatever it may be. The procedure involves reducing size of the breast, which may combine with breast lifting and nipple reconstruction. So this here is a keyhole incision right here. Plastic surgeons have these round sizers, and it has sharp around it, and they'll kind of make a marking around the nipple area, and then that's where we would use our blade and cut in there, and then we would take this area and move it up and bring the nipple down, and then we'd have a lifted breast and a reduced breast. A transverse rectus abdominis, which is a tram flap procedure, is performed to reconstruct the breast without the use of implants. So we don't always have to use implants. So the tram flap is released in the abdomen area. The flap is transposed into the defect. So we would lift it up here. You see, we incise it and then we lift it up here. And then the flap is sutured. And so that makes a breast. In this procedure, a pedicle graft, including fatty tissue, muscle, and skin, is transposed from the lower abdominal area to the mastectomy site through a tunnel in the abdominal wall. Look again. We incise this. We keep all the necessary arteries and veins for vascularization. We lift it up and tuck it up in here and make a breast. And that's what it looks like. Deep inferior epigastric perforator graft is another alternative for breast reconstruction without the use of implants as well. Deep inferior epigastric perforator procedure transplants a free graft from the abdomen to the chest wall. This procedure uses microvascular anastomosis techniques. Remember, we need all the vascular we can get because we have to keep the skin and everything alive in there. Blood supply of the tram flap graft is carried from the recipient site to the donor site. Recipient site, and then we move it up to the donor site. The microvascular free flap obtains its blood supply from the recipient site. Abdominoplasty. The pathology is remove excess skin from the cosmetic or medical purposes. After significant weight loss, the redundant skin of abdomen hangs flaccid, making movement and daily activities very difficult. The surgical procedure is excess skin and adipose tissue is removed from the abdominal wall. Muscles may be tightened. Procedure may include liposuction to remove excess deep fat, peniculectomy to reduce a loose apron of tissue that arises from the lower abdomen. Use of mesh for reinforcement of the muscle layer may be required. One of my coworkers' son had this done, and I was in on the case, and we actually it's very taut. So the patient, when they woke up, was bent a little bit, and then eventually they have to work that to get it straight. We want it to be so tight. So, and we put tubes in for drainage because we're going to take a lot out of there. Okay. Especially if they were like 400 pounds, whatever, and lost 250 pounds. There's a lot of loose skin, a lot of things going on. So the overview is debridement of burns, your split thickness skin graft, full thickness skin graft. Don't forget about your flap graft, Mohs micrographic surgery, and scar revision. Your pedicle graft, here's a good one. The pedicle graft is used when the recipient sites require skin and deeper tissue layers to fill a large tissue defect. The reason why I like this picture here is because it's blown up from the other slides. So you can see we open it up, right? We got everything we wanted, and then we transposed it up here. So then this will just be sutured shut, and then you still got your artery coming up here, keeping the blood flow going, making that flap. And that is the last slide, guys. Since this is to be seen on Thursday, any questions, comments, concerns, or I need to go back over, we'll do on Monday. Okay, so think of any questions that you may have, write them down or remember them, and we will talk about it further on Monday. You guys have a great 4th of July.